Good evening and welcome to the April edition of the MyCP webinar series. I'm really excited to have my friend and colleague, Dr. Jacob Kean, here to talk about discovery and improved health. I see I made a typo in the slide. I don't have the Y there for discovery. Got it right in the other places, and how your lived experience can really contribute to new findings in cerebral palsy. So I'm your host. This is the voice of Paul Gross. Maybe the screen of Paul Gross. Our agenda for this evening is just give you a little bit of an introduction to what I refer to as the new CP Research Network, since we merged with CP Now back in January. And then I'll turn it over to Jacob Kean to give his presentation, and then we'll take an open Q&A. I'm going to mute everyone for starters, just to make sure we don't have additional noise. Okay, so as I mentioned, we did a merge between what you see as these four logos or these four brands, but the efforts of CP Now, which included CP Daily Living, and CPRN, which included MyCP, all into one entity, one 501c3 nonprofit, going under the name of the CP Research Network, or the Cerebral Palsy Research Network. The most visible manifestation of this merge will be our new website when we get it out. It is a very big effort to pull two blogs together, two very different kinds of information resources all together. So we're working diligently on that. We showed a sneak peek recently. We're excited to bring that resource out, but the mission of the merged entity is slightly different than what you would have heard as the mission for. I'm going to let people know that I've been having intermittent internet problems, and so Jacob, I'll ask you to text me if you're actually having problems seeing me or hearing me. But I just got a notice from my Zoom, a little unstable. It's from my internet connection. So the mission is optimizing the lifelong health quality research, education, and community program. I find that people need a little as to what, and so the CP Research Network is first and foremost now with this merger a 501c3 nonprofit. And what we do is we organize a collaborative network of hospitals and associated universities, and the clinicians and therapists in them, along with researchers and patient advocates, all who are very interested in seeing research improve outcomes for people with CP. So it's very spread out, and I'll give a picture of that in a moment. But we come together in the form of how we share data, and it comes together in a data coordinating center, which is really a set of services provided at the University of Utah's Population Health Sciences Department. And actually, Dr. Kean is the principal investigator for our data coordinating center and really coordinates a lot of the activities that support our research. And we exist to really accelerate these findings that can improve outcomes. And we do it through a series of infrastructure, such as databases. So we have these two registries, a clinical registry, which gathers information from when you visit a hospital, and it gathers information from people in the community. So as June Kales, who was on the webinar, likes to point out, to refer to people as patients is really only true when they're in a hospital setting. And so being able to gather information from people in the community is really, really important. And then additionally, with our merge with CP Now, we've taken on these education and well-being programs. MyCP is a very important component of what we do. And what it really is a web portal that is part of the CP Research Network. And in fact, in the new website, the two sites come together, and it will be embedded as a standalone piece within CPRN.org. And it really allows the extended community to come together. It offers participation in the community registry through surveys that can be done on a mobile device or on your computer. It allows people to have discussions about research in a place that is secure and private. So people can either have their name be known or have it not be known. In terms of your ability, we can engage the clinical community to participate in discussions, which is quite difficult to do in an environment like Facebook. And then it's a series of tools, and we have the first tool in place today, but we envision numerous other tools to really enhance care. And anybody can sign up, it's free, it's at mycp.org. So to give you an idea, the clinical registry, which is, we're picturing a bar graph from some of the data on the left, it has about 5,000 patients in it today. This is from a snapshot back in August when it had 4,485 patients. And this is just to give you an idea of the one data point that we capture, which is the gross motor function classification system level for each person seen at a CPRN center. So we've got about 15 or 16 sites that are contributing data to this registry today. And you see the distribution, this sort of U-shaped. One thing really important to point out is that it's not a surveillance registry trying to get a view of the population. It gets a view of people that come to hospitals to be treated. So that's really important. So it's not intended to predict sort of trends, is CP going down or up based on treatments that are being done? Are people getting more or less, severe in CP? It's really intended to capture people being seen in the hospital and see the treatments they get and the outcomes that they have. So that's just an example of some data that we have in the registry. And then on the MyCP side, really combining not only people with CP and caregivers, but it's also we have 165 providers. We have 31 researchers, people from industry participate, or just people that are advocates. So MyCP currently has 1,222 people, and you see roughly 1,000 are people from the community that either have CP or caregiver to someone with CP. Sorry, my mouse seems to be around. Those 976 are registry. So the CP Research Network has a number of programs. We refer to our four pillars or cornerstones. So community engagement is a big piece of what we do. And this picture here is from the 45 people that we assembled in Chicago in 2017 when we worked on Research CP to set a patient-centered research agenda for cerebral palsy. And so we had people from across the community, parents, caregivers, people with CP, that all participated in this agenda setting process. In fact, I just admitted somebody who had joined us there in Chicago into the meeting. And then here on the right, we have a picture of a subset of our researchers that are, some are clinician scientists, some are epidemiological researchers or other types of outcome researchers. And we get together twice a month to discuss our research, and then we get together in person in non-COVID times once a year. We actually have our virtual investigator meeting next week, where we'll have about 45 people online for 2 days working on our research. And this is the group that works on research and quality, but it also includes members of the community. And I apologize, I keep having slides on time. We also have educational programs. The Cerebral Palsy Toolkit that was developed by CP Now is a key piece of this. And we think our website, when we launch it, is going to be another really key piece where we have a lot of information that's really intended to help educate the community. And then, of course, MyCP that I've talked about as a platform is another one of our programs. And then we've started recently working on health and well-being programs. Currently, we have 10 people that are participating in the Mentor program, which is a mindfulness, nutrition, and exercise program that's put on by the National Center for NCPAD, National Center for Health, Physical activity and disability. Sorry, that I always have to figure out what that stands for. And so they're in mid-process. They started on March 29th, and they're in an 8-week course to work on those areas. And then we've also been working with Shriners to develop a program that's called BFIT to get children to be able to participate in physical activities, adapted physical activities to improve their health and well-being. So the network itself, the clinical sites are spread across North America, as we have about 30 sites at this stage. The green pins are that are actively collecting data into the clinical registry. The yellow pins are sites that are going through the technology process of rolling out how we collect that data in the electronic medical record. The red pins are sites that are still going through some of the paperwork of compliance. And then the blue pins are sites that have said, we want to participate, but we aren't quite ready to sort of sign the agreement, sign the data sharing agreements, and do our protocols to get up and running for collecting data. But those do come on board over time. So it's quite broad across the US. And if you go to cprn.org, you can look at what are the names of all the actual sites. So as I said, we exist to really accelerate research, and this gives you an idea of our research pipeline, where the left-hand side are the concepts that are being developed, and some, just are spaghetti against the wall, and some really move all the way along through this pipeline to be approved as a concept, to go and submit to a funding agency and get funded, to get implemented as a study, to be executed, for the results to be written up, and for those results to be published, is sort of the cycle. And then then the goal is to take that evidence base that we generate and roll it back into clinical practice, so that we're always working off of evidence-based medicine for the guidelines for the sites that are participating. The blue ovals represent research projects. The orange ovals represent quality improvement projects, and these are just two different ways to improve outcomes. So with that, I'm looking forward to turning it over to my friend and colleague, Jacob Kean, who is an associate professor in the Department of Population Health Sciences at the University of Utah. And as I mentioned, he's the principal investigator for our Data Coordinating Center. He's also the director of the University of Utah Health Learning Health System, which is this big system-wide quality improvement project. And he's also very involved with the VA and is a research health scientist there. And so with that, I'm going to turn the keyboard, the screen, the microphone over to Jacob. Dr. Kean, you are up. I've stopped sharing.
Can you hear me as a start?
Yes, we can.
Okay, great. And let me move my slides around here and share screen. Are you seeing my slides now?
We are.
Okay.
You're not in full screen. You're not in full screen. Yep, there you go.
And
we're seeing your presenter mode right now.
Thank you. I will switch that. Okay, you should see the full slide deck.
Working. It's good.
Fantastic. Paul, thanks for the warm introduction. And thank you also for the great lead in talking about MyCP, talking about the data that's coming in from different sites in CP Research Network. It's a great lead in to talk about discovery and improved health from your lived experience with CP. Historically, there's been a focus, I think, in medicine and research on paternalistic perspectives, this idea that care providers and scientists make the best decisions without the input of patients, without the input of research participants. And this focus on paternalistic medicine has been a swinging pendulum over time. There's been an increased focus in patient centricity, an increased focus in provider centricity, over different epochs, but research has primarily been what we might argue as paternalistic. And patient-centeredness there is newer. But there are numerous examples of work going on today that represent a new perspective in research. Certainly, one of them is the Patient-Centered Outcomes Research Institute, or PCORI, which funds research that can help make patients and those care for them better informed about the healthcare choices they make, and so they're guided by information that they'll use every day. Another example is patient-reported outcomes. These are outcomes that collect the status of a person's health condition directly from that person without interpretation by a provider or filtered in any other way. These are becoming more important as FDA has emphasized their use in drug studies and in labeling decisions and other sorts of things. Another area is shared decision making. This is, like I moved slides there. This is a process in which clinicians and patients work together to make better decisions, selecting tests and treatments based on patient preferences and on recommendations from the doctor. This is also called a discussion among peers, the patient being the expert in his or her medical condition and a provider be an expert in treatment. And so together, the shared decision-making process results in more patient-centered outcomes. There's broad stakeholder engagement in a number of things, and this has gone with the moniker of nothing about us without us, influencing policy, research, and care very broadly. In other places, this is called lived experience. This is a broad term that encompasses many of the terms above. But as we go over time, there's been growing interest in incorporating a person's lived experience in research at the point of care. Why? Well, there's greater relevance of the efforts in support of the lives being treated and answers being generated in research. So patient-centered research, theoretically, and I think many times in practice, is research that is more focused on the things that matter to patients. As a result of incorporating lived experience, the research is more useful, and the translation is greater from artificial research contexts to real-world contexts, because the focus is on the real world and the lived experience from the beginning. Focusing on patient-centeredness and the lived experience is nothing new in CP Research Network. In fact, this was born in CP Research Network from the beginning. Includes a variety of different things. Certainly our work with Research CP that Paul cited that took place in Chicago in 2016, I believe. This was a PCORI-funded initiative to establish a patient-centered research agenda. There were hundreds of participants online. They went through a process where research ideas were ranked. There was a group that came together in Chicago and prioritized that research agenda, and this is available on the CPRN website. Paul also talked about MyCP. MyCP is a community resource for CP. He talked about it. I'll talk about it a little bit later, but it's a rich source of information and a rich place to engage. We have a community advisory committee in CP Research Network that advises on the strategic network or on the strategic direction of the network, and is very influential. The leadership of CP Research Network. This is a network that was founded by parents of children with cerebral palsy. And the science that we conduct in CP Research Network is prioritized based on Research CP and based on many voices to help prioritize. It also allows the opportunity for research participants to be engaged at every level of study development. As mentioned before, lived experience means many things. One of those meetings is related to the information captured about living. And this information that's captured about living is growing exponentially. In today's world, we're awash with information, but it sits in these information silos. Healthcare providers have information about health, government has information about its citizens, businesses have information about their customers, and this is generally kept separate for business interests and government interests and healthcare interests. But it's separated to protect individuals as well. And there are new technologies that allow some of this siloed information to become linked, but still to preserve the privacy of the individuals who are represented in these information silos. So these are called privacy preserving record linkages. And using these technologies, each person is represented as a unique key. The key is a nonsense string of numbers and letters. Instead of a person's personal information, the key represents that personal information and is unique to each person. And as a result, the key can unlock the information silos. A person's lived experiences can then be connected and understood, and the person's identity is not shared in the process. So where we have silos of information today, when we turn identities into keys, we can unlock the information in the silos, and we can fully capture the lived experience in cerebral palsy and in lots of other populations. One example of this is a study by Centers for Disease Control and Prevention called the Clinical and Community Data Initiative, or CODI. The focus of the CODI project is on childhood obesity. Childhood obesity affects 14 million youth in the United States. And research that assesses childhood obesity interventions is limited because researchers cannot easily link information to learn which interventions are effective. So there are lots of silos in this space. The solution that CDC came up with was to create these unique patient keys for each person in the study and unlock these different information silos. So unlocking it meant you could take community information that was available and weight loss information or information about weight loss interventions that were available, and also health information, and link those together while never exposing the identities of the people who were involved in the study. And as a key benefit, CDC is learning what childhood obesity interventions are effective. They understand data from a variety of sources. They understand the lived experience in a fuller way. And so they're able to look across a number of different silos and evaluate the effectiveness of these weight loss interventions. Another study that used privacy preserving linkage is a study called Short and Long-Term Effects of Antibiotics on Childhood Growth, or the AbX study. This study is focused on whether or not there were health consequences to children who received antibiotics before age 2. One of the limitations of doing a project like this was in a single health system, not all the antibiotics that are prescribed to children come from providers who work in that same system. So a child might see a provider in system A and receive an antibiotic from a provider in system B. Maybe one's a hospital and another is an urgent care facility or a pediatrician's office, or you name it. And so all of the total lived experience around the antibiotics isn't captured in a single system. Without breaking down the silos, the lived experience is not fully captured. And so the solution, again, was to create patient keys for each person in the study and unlock the information silos. In this study, the silos were an administrative claims database, which showed the antibiotics paid for by the health plan, and the electronic health record, which showed the antibiotics prescribed by health system providers. The key benefit to stitching together these two different lived experiences was that the true impact of the antibiotics on children could be understood. You could look over the short term and the long term to see if early antibiotic use affected things like height and weight and other sorts of things around childhood growth. Another study that's really quite interesting is the National Institutes of Health All of Us study. It's different. It's really quite large. It intends to enroll 1 million people. And as the amount of data grows in this big data repository, patterns will emerge that wouldn't be visible in smaller studies. So you get a lot of people, not unlike what we're doing in CP Research Network. Of course, we're not at this scale at all, but getting large numbers so we can study small differences or rare occurrences. The NIH All of Us study reflects population diversity of the United States. The initial plan is for a 10-year study, but they've suggested that it could go longer. And the study includes many types of information, electronic health record information, blood and urine tests, and maybe later wearable technologies. Like other studies that use a variety of these information sources, the lived experience of participants was not fully represented in any one of these silos. So you had participants in the All of Us health study that got some care in Health System 1 and other care in Health System 2. Those lived experiences ordinarily sit in silos and aren't linked. And so NIH All of Us took on privacy preserving record linkage in order to create patient keys, unlock the silos in the different health systems, and put together a complete representation of the lived experience. In this project, about 10% of the population had clinical information in more than one health system. For those that had information in multiple health systems, 50% had conflicting information. So half of the 10% or 5% of the study population had things that differed between the information silos, like different race, different gender, different age, and things like this that would really compromise what they were able to do in the study. The key benefit here is reducing information fragmentation, stitching together the lived experience so that the study results were accurate and meaningful. CPRN, in partnership with Dr. Michael Kruer, is doing a study that involves privacy-preserving record linkages. And the study is led, as I mentioned, by Dr. Michael Kruer at Phoenix Children's Hospital. It's called the Genomic Insights of the into the Neurobiology of Cerebral Palsy study. And in this study, the CP Research Network clinical registry sites will refer patients with unknown causes of CP to Dr. Kruer in Phoenix. The information silos in this study are silos around genetic information and clinical records. In this case, the genomic information sits at Phoenix Children's Hospital, and the clinical records sit in the CP Research Network Clinical Registry in the University of Utah. Like other studies, the solution for us in this project was to create patient keys for each person and unlock these two information silos. Key benefits or expected benefits of the study, which is underway now, include better prediction of an individual's symptoms over time, assessing a family's risk of having additional children with cerebral palsy, and personalized medicine. Linking this genomic information with clinical records helps identify which genes correspond to which clinical conditions and potentially drive which treatments are provided to those persons. As Paul said earlier, we talked a little bit about MyCP even in this slide deck, but we'll do a little so more in a little depth here. It's a rich resource that includes a portal, a commons, and resources for the CP community. it's a community-powered registry as well, and it's really designed to capture the lived experiences of persons with CP. So signing up for MyCP and completing surveys captures critical parts of the patient perspective or experiences outside of the clinical setting. The clinical registry and CP research network is great, but it captures clinical information. MyCP is designed to put its arms around patient perspectives and experiences outside. And as you can imagine, linking the two represent the lived experience of CP more completely. So here within CPRN, we have two different information silos, as I mentioned, the clinical registry and MyCP. We can create patient keys. We can unlock the information in those silos. And as a result, we could understand the long-term outcomes of clinical interventions. So a person signs up for MyCP, completes yearly surveys on a variety of different things, and then linking the clinical registry with that information shows services that were delivered in clinical settings, and then over time, 2 years, 5 years, 10 years, when there's information in MyCP represented as completed surveys, we can understand the long-term impacts of some of those interventions in ways that clinical centers can't, frankly. You know, a potential example within CP Research Network is to link these MyCP data, this community registry data, with wearables, Apple Watch data, with Fitbit data. Doing a project like this, although this is just an idea, could provide the key benefit of understanding how mobility improves quality of life in CP. We may be able to link Fitbit in this way, capture, or Apple Watch in this way, capture how someone's moving around the community, and then begin to understand the relationship between that and those yearly surveys that are completed. Last slide for me is really an invitation, I think, on the part of CP Research Network, and an invitation broadly to the community to think about the ethical considerations of data sharing. So we're built from the ground up as a patient-centered organization. It's very important to think about how the community feels about data sharing and about linking these different data sources. To meet that need, CP Research Network plans to convene stakeholders to consider use cases for linking and for data sharing, and to look at examples from similar initiatives to try to understand the best way that we can use data to impact the lived experience, as well as monitoring it. You know, in the future, we expect to explore more data sources. The Fitbit or Apple Watch example that I offered is just one. There are many, many potential data sources that could be linked, and more becomes possible as these technologies are adopted. I will stop there. I'll turn it over to Paul and would be glad to answer questions. Thank you very much.
Great. Thank you, Jacob. So now is the time when we just sort of move to open Q&A. So if anybody has sort of questions about how this works, scenarios that we could explore, any of that, kind of fair game. So, and if somebody doesn't ask a question, I'm going to give you a softball in this area, Jacob. So, Jacob, I know you're personally passionate about this. Can you talk a little bit about how you're looking at using this technology in the VA and what you're hoping to find, and maybe about some of your future plans where you think, because of the potential of this, you placing some sort of big personal bets on it.
Yeah, no, thanks, Paul. In the VA context, care is fragmented. There are some veterans who choose to receive their care in VA, some veterans who choose to receive their care in civilian health systems, and some who choose to use both. To understand the complete lived experience, or in this case, the clinical experience of veterans, we did a project around traumatic brain injury and focused on linking VA records with those of civilian health systems to begin to understand who uses both systems, what do they use both systems for? Are there differences in terms of costs and quality, differences in services that are provided? So we can begin to better meet the needs of individuals wherever they are. And that may mean more contracting with civilian facilities to provide care, may mean developing or enhancing or extending existing VA services. But the focus in that project was breaking down the silos, again, with a patient key that preserves the data, or excuse me, preserves the identities of veterans, and looking at the healthcare use in a variety of systems.
Great. I've got more that I would either explain or ask, but I'm going to just want to make sure that people that are signed on, questions for clarity, those ethical concerns that Jacob raised. Anybody have any thoughts or questions about that? I will say that I don't know how long each of you that have signed up for MyCP signed up, but one of the things you experience, and I think probably stops some people when we sign them up, is when you click on that you're a person or a caregiver, we give you a form, and then you say what your relationship is to the person with CP. And then we ask a fair number of questions. And one of the questions we ask is, what is the full name of the person with CP? And we make a little note underneath and say, we're not going to keep this information. We're using this, and there's actually a little FAQ that we take you to, but we actually gathered that because the way these privacy preserving linkages work is we take your full name, your birth date, your biological sex, and we generate one of those strings that Jacob showed as an example, which can't be reverse engineered. Nobody can take that and say, oh, this is June Kales. Sorry, June, I'm just looking at your face there, but so you can't work backwards to it. But if two data sources can generate this, then an honest broker can say this row of information about this person is the same as this person. And that is how you can sort of expand this set. So that's why we asked that question in the MyCP sign up. It's a critical piece to be able to make this linkage to, say, the clinical registries, and to be able to generate these keys that Jacob was talking about as a way to connect pieces.
This is Duncan. I do have a question for you, Jacob. Have you noticed any significant difference between input responses from a veteran's viewpoint? Because they tend to acquire their disability later in life, or certainly no earlier than their 20s military service, as compared to the CP population that have a lifelong disability. I tend to see people who acquire a disability in life maybe being more vocal about their advocacy, self-advocacy, than folks with a lifelong disability who, as you pointed out early, tend to have a longer exposure to a more paternalistic care system?
It's a great question. We haven't done those comparisons. there are a set of tools. I see Debbie's picture here and know that she's involved in this and others, but a set of tools that were developed in Northwestern, patient-reported outcomes called PROMISE, that would allow those kinds of direct patient population communities to one another in terms of looking at disability and looking at impacts in a number of different ways. And so, although it hasn't been done, I think it's an interesting suggestion and one we could pursue.
And
Thank you.
Duncan, you know, that's a great question. You know, I do agree with you that I think that people that acquire their disability later in life, I think they seek out support groups. I think they're more willing to advocate for themselves. And I think that's why the CPRN is so important for people, especially people aging with CP, is that there's been a lot of silence. And I think that this is a way to get numbers and get groups of people together that have the lived experience so that we can actually, you know, maybe have an influence on third-party payers and, you know, get that Medicaid cap up from 10 therapy visits to however many is needed. And I think that's why those of us that are, you know, Mary Gennady and Mark Peterson and myself and a whole bunch of people are doing big data research now, looking at Medicaid databases and stuff to try to get this data together to try to convince third-party payers to change the policy. So I think you're right, but I think I do think that CPRN and MyCP is a way for specific families and adults with CP to have a voice that they haven't had before. You know, autism, they're huge advocates. The Down Syndrome Society, huge advocates for people with Down syndrome, and CP has been kind of silent in the past. And I think this is a way to gather people together to have one collective voice. So that was a great question, Duncan. Thank you.
And then I guess the only thing I would add is if anyone doesn't have enough on their plate and wants another project, it might be interesting to match some of those veterans with acquired characteristics who might be stronger advocates as mentors to folks aging with cerebral palsy who maybe don't perceive themselves as having the same self-advocacy power or skill set.
Right. I'm going to take some questions from the chat. I would say though, to connect Debbie and Jacob's points, like about PROMISE, Duncan, if you remember back to when you took the adult study that's in the community registry, one of the things that Jacob pushed for was using PROMISE because of the ability to do a comparison of the CP population to the rest of the population. And you know, we've got about 220 people, and we're trying to get to 500. It's a long haul, but that's why it's important that you communicate out to your colleagues that you know that have CP and ask them to participate in MyCP. So Susan asked the question, do we have a hospital in the Metro DC area, and do we need one? So we don't think of it as need per se at this stage. Most of the way hospitals are selected is the physicians within the hospital self-select. They say, you know, we really care about this population, and I'm not, some people don't care about it, but they care enough about it to do the work to join the network. And so, and we have a smaller number of hospitals, adult hospitals. So what I would say is if your hospital is interested in participating in research and quality improvement for adults with CP as an example, then by all means, it's really making them aware of it, and then we get connected with them and help them through it. So we would welcome that. Jacob, the question asked, can you explain lived experience?
Yeah, lived experience is a term used variably. I used it in this talk to think about the different ways that these information silos capture how people move through the community, how they engage in shopping and in healthcare and in recreational activities and whatnot. So each one of these information silos has a different piece of that. And so in total, it would be one's lived experience. And I imagine that it's fractured in those different silos. Hope that helps.
Okay, any other questions for Jacob? Oh, I see there was a comment about that, which was children's silos versus adult silos.
Oh, for sure. We haven't talked much about that, but right, as children just in care settings, transferring from pediatric care settings to adult care settings, there isn't always continuity. And so that would be a place where there was silos between childhood and adulthood and information. Certainly school and out of school and these sorts of things are another place.
Right. And I think, Debbie, you could comment on this, or Duncan. Lived experience has been used a lot in the adult SIG group that's been formed as part of the American Academy for Cerebral Palsy and Developmental Medicine. And I think it's really just getting at, there's a clinician's view of what it's like to have CP, and then there is your lived experience if you have CP or if you're a caregiver. And it's really trying to honor the importance of that experience as a different source of knowledge than someone who is in a treatment kind of relationship. Okay, couple more minutes left if we have questions. If we don't, we can always, wrap early. It's not a bad thing. Anybody else have a question?
Well, just let me make a comment on
Sure.
your last comment. It's extremely important to those of us who do research to have people with the lived experience, adults with CP, parents of children and adults with CP in our research advisory groups. I don't think there's anyone in the country now that's doing research in CP that doesn't have some kind of parent or lived individual with CP on their advisory group. I know NIDLR, one of the federal agencies that funds, similar to NIH, kind of a part of NIH, they won't even consider your grant if you do not have people with lived experience on your advisory board. And way back when, we just never did that. We never thought about it, but it's so important. So, that's something else you can kind of become involved in as much or little as you want, but we're always looking for adults that have that lived experience or parents of individuals with CP to be on our advisory boards. And it's extremely important for us because, we could be the most brilliant researcher, design a fantastic study, but, we're just not recruiting right. Our measures might not be right. They might not be things that are important to individuals with CP or parents of children with CP. So we have to have people with that lived experience on our advisory boards. So, think about that. We're always looking for those groups to help us out and to advise us. And that's kind of new in the last, I'd say, 10 years. Wouldn't you say, Jacob? Probably.
I think that's true. And that's one of the things I was trying to reflect in that switch from paternalistic perspectives to engage perspectives. So I agree with you, Debbie.
Yeah.
Jacob.
Invaluable advice. Yeah.
Sorry. Jacob, it's David here. Question for you. In regards to data sources, I put this in chat already, but I'm curious. I live here in Canada, but most members are in the US. I'm just curious, how does it work for you at the local state level or the federal level? Are there various data sources in those two areas that are working with you?
It's a great question. I would say that this is starting to happen. And so we're talking about linking with a variety of sources. in VA work, for instance, even just bringing different government data sources together. So housing and urban development with VA healthcare, or CDC with Health and Human Services, or
Right.
these sorts of things. And so the cryptographic technologies that make those identifiers have been around for quite a while, 30 years or so. But
Right.
really, the software to do this and the ecosystems to be able to stitch together these lived experiences have really only developed in the last few years. And really, CP Research Network is an early adopter as clinical and community registries of this technology. And so I think that we're in a driver's seat position with respect to what we can do and potentially the partners that we could attract because of
Right.
our early presence in this space.
So I'm going to try to tease apart the sort of flow of questions in the chat. So Lily Collison wanted to comment on Debbie's statement. So Lily, I'll turn it to you.
Just in terms of families getting involved in research, I just completed a course with CanChild, which is family engagement in research. And even though I had done some research for myself, like I'm a family member, I'm the parent of an adult son, and I did the course, and I must say I would recommend it to anybody who is interested in sort of contributing the lived experience, because that course, a 10-week online course available for free to anybody who would like to take it. And I did it, and it was, I must say I would recommend it. It was very useful for people who want to get involved and contribute to the research as people with lived experience.
Great, thank you, Lily. Okay, and I just did a quick Google of that, and that's pretty easy to find online if you search for CanChild family engagement.
CanChild, FER, yeah.
Yeah. John Pokawski had a question about, can there be a silo from the physical therapy or rehabilitation arena?
Yeah,
I guess that.
Yeah, no, I think they can exist in all sorts of places, and especially if those two different services aren't under the same health system roof. I would expect that a silo does exist there.
And part of the problem is that as Jacob has said before, we're not all using the same measures. We're working really hard to coordinate that, hopefully for future. But you have all these different assessments that different people in different facilities use, physical therapists and rehabilitation specialists. And so we can't compare our data. It's very, very difficult. I work with an international group in the Netherlands, Australia, Africa. We published a blood pressure manuscript. We've published a pain manuscript, but we had to ditch a lot of our data. We could only pick the variables that were the same in all of those data sets. So if we start using a uniform set of assessments, it will be so much easier to compare internationally all the data.
Yeah, it's a good point. And that's why I love the number of people that are sort of signing on to what we're doing, and the fact that our data elements got pushed into the leading electronic medical record really helps. And now there's work being done to take some of those into the CP CDEs. And so I think all that sort of standardization can help. Heather, I'm trying to sort out how to just ask your question without, what's the core thing you're getting to, but I'm wondering if you feel like you can summarize your question in a way that it could be answered by the group, especially given that we have, some, we have a fading number of clinicians on the call, but do you want to try to summarize?
I'll try. Just having watched research being allotted to different groups. I'm one of the older participants at MyCP. I've been there since its inception, I think, Paul. Yeah. But in my life experience, I know that there's different perceptions for different groups of people. And for whatever reason, CP, even though we're a large group of people, 17 million around the world, roughly, we have the least amount of funding, historically speaking. And I know we're trying to turn that boat now. So we get some of the funding, but how do we deal with changing the perceptions that are still out there?
Yeah, that's a much harder. I feel like I have a real grasp on how to change the funding scenario. It's not fast, but I know how to do it and have like done it in other disease areas. So, but changing perception, I don't know as much about it. I know Debbie, you've worked in this area a bunch. I don't know, Jacob, if you have. I don't have a good handle on that.
I think that, autism has a huge parental backing. That's what pushed the research and eventually the funding for autism, I think. And as far as perception, that word is a kind of a conglomerate of a lot of different things.
Right.
CP never used to be on NIH's 100, goals for funding. I think about 10 or 15 years ago, we made it to 99. And now it's moving up. And with the development of the CPRN and Paul and pushing and all the research that's going on, the phenomenal research now that's starting with CPRN, it's going to become much more apparent. But Heather, I don't know how to answer that question as far as the perception. I know there are I think parents pushed the autism funding. I think Down syndrome, the same thing, parents pushed it. Down syndrome, I think there's more research on Down syndrome than there is in any other intellectual and developmental disability. They've been researching Down syndrome for 50 or 60 years. We've not been researching CP for that long. It's relatively young in that area.
And I will say in Down syndrome, I actually tracked how, because if you look at the ramp, that's ramped up substantially in the last few years. And it's one of the things that's amazing, for better or for worse, is the role that relationships play. And what happened was somebody from the Down syndrome Foundation built a relationship with a fairly senior person in NICHD and got them to engage in a series of things that has resulted in substantial funding. And then researchers will follow where their funding opportunities are. But there's another way to move research, which is get a community of people that they can engage with so they can see the impact of their work. They know what's important. And so that's the approach that we're taking.
And I think another thing too is, cerebral palsy is so heterogeneous.
Yeah.
Down syndrome is pretty straightforward. Autism is pretty straightforward. As a researcher, it's really hard for me. I'd have to get 500 subjects to be able to divide them into each of the GMFCS levels of function and cognitive function. So it's such a heterogeneous group that I think that's part of it, Heather. I think that's part of the perception. People don't understand that, cerebral palsy means you can have intellectual disability. You don't have to have intellectual disability. And I think that's part of it. It's just hard for people to wrap their head around the hugeness of the group of people.
Agreed. I want to be conscious of the time. It's past 9 o'clock on the East Coast. Jacob Kean, thank you so much. It's a pleasure working with you. I'm really excited that you're so excited about this area. Really helped take something that I believed in strongly and made it a reality. And I do feel like CP's on the leading edge of this, and I'm hoping we can drive some of this discovery and make for some improvements. Thanks everyone for dialing in. I appreciate it. I'll send out a link to the recording sometime in the next 24 hours. Thank you all for attending.
Thank you all. Thanks for having me.
Bye.
Have a good evening.
Thank you.